Okay, everybody, welcome to our webinar, Dermal Filler Danger Zone and Complications and How to Treat Them. I'm Wendy Pickett. I'm one of the instructors here at Pacific Northwest Aesthetics Academy, and this is my partner, Kathy Kramer, and our Chief Operating Officer, Saskia Magner. And for those of you who've taken our classes before, you know us well, hopefully by now. And I've been in the industry for 7 years and have been doing teaching for 4 and love it. And Kathy has been in for about 8 years, and Saskia has been in the industry for longer than both of us combined. So we felt very strongly that we wanted to do a webinar that's interactive. You all can ask us questions about dermal filler danger zones, the areas to avoid, complications that can happen, alternatives to the care. Treatments that you're doing to your patients, but we all should also realize that anytime you're sticking something into your patient's face, that it can lead to complications. So we definitely have the areas that we're going to highlight today with some statistics as far as the percentage of complications that we see in that area, but really we see complications all over the face. So we kind of throw back to what we have learned. And in our basic injectable class, we teach the safest possible method of injecting dermal filler. So we're going to talk a lot about that specifically today. First, we're going to do anatomy overview, and then we're going to move on to the different areas of injections, possible alternatives, and then we'll have discussion at the very end. So if you all would hold your questions, maybe keep a notepad handy and write them down, because we very likely will answer those questions at the very end of the webinar if we haven't already answered them as we go through the didactic portion of this. So I'm going to turn this over to Kathy now, and she's going to give us an overview of anatomy of the face and talk about some of the things that will be helpful as you move forward through your aesthetic career.
All right. Hi, everyone. Well, Saskia has graciously agreed to let me write all over her face. So we're just going to go through, and I'm going to go through primarily the arterial system, but as we all know, veins, arteries, and nerves all hang out together as friends. So we know that there's vasculature for wherever there's an artery, there's also a corresponding vein. So we'll kind of talk a little bit more about that as we go. So we know, let me just grab my new friend here. When we look at the skull, anytime we see these little openings or these foramen, here is one right in here, here is one down here, those are in the bone so that vessels and nerves can pass through. So there's some important ones of those we want to talk about as well. So when we think of our carotid artery coming up through the neck, it's going to come up, and if I had Saskia clench her teeth, which she did for me, I'm going to know that right in front of her masseter, right about here, is where this artery comes up and begins to branch into one of the facial artery branches. And it's going to make this journey all the way up the face, like so. So it comes up, and if you actually see this on a cadaver, it does not look like this. It looks like a swirly, almost like an old-fashioned phone cord or a piggy tail. It's very swirly. It's really interesting when we think about how we perceive things. And we were at a cadaver lab, and Wendy goes, wow, that thing's so curly you could barely hit it. And my thing was, that thing's so curly you could barely miss it. So we just need to be mindful that it's there. In most of it, it's going to course up, and it's going to be a little bit lateral to the NLF, but in a small percentage of people, it actually runs right along the nasolabial fold. I believe the stat that I saw was I can't remember, but it's just about a centimeter over from the ala of the nose. So that continues upwards, and it's going to now become the angular artery. You're going to have a big branch of the nasal artery, and then we're going to come up, and you're going to have your supratrochlear and your supraorbital arteries. Along this side of the face, we have branching that comes up, and right along the top of that masseter is the transverse artery. This guy doesn't usually get us into much trouble. We know that when we, I'm just going to palpate under her eye, this infraorbital foramen and typically you can feel it. And a lot of times if you have like a little cotton tipped applicator, your client will go, oh yeah, that's it, because there's a nerve that passes through there as well. Turn forward for me, Sas. Look straight ahead. Typically that is going to be right at this mid-pupillary line. So we know there's a vein and an artery coming out here, feeding this part of the face. So now, oops, green, wrong color. So this artery is going to continue up, and then we have a couple of branches of our temporal artery moving forward and here. So when we think of vascular compromise, we think of getting filler into these arteries. I challenge you also, it may be that you just put too much filler in one place and we actually have compression of the artery from product and or edema. So we really want to make sure not to overfill our clients. So this is kind of a basic overview, but the very interesting thing is that there is communication of all of these arteries posterior to the orbit. What that means in basically, basic terms is that any of these arteries we were to inject, should product get there, the press of our thumb on the syringe can actually override the arterial blood pressure and cause backflow into the central retinal artery. So anytime we're in the nose, temple, even the nasolabial fold, we are running the risk of compromising that arterial circulation. It's 12.2% of all instances of blindness were frontalis, 38.3% were glabella. It was 25 and some change percent were injections through the nose. Well, those of you who have taken our courses know this is all kind of a no-fly zone for us because the sequelae are huge in these areas. They're rare, but they are huge. And none of us want to create blindness or tissue necrosis or any of those problems. Now, as we said, along with our arteries are our friends, the veins, and there's this venous communication in the posterior part of the face called the cavernous sinus. I remember as a teenager, my grandmother telling me that you can't pick a pimple on your nose or you'll get a brain infection, and I thought she was crazy. Well, we now, in researching this triangle of death, and you can hear Dr. Sandra Lee, Dr. Pimple Popper, Dr. Oz, all of them, if you Google triangle of death on the face, will address this area. And that is because of this communication of the vessels that not only could lead to infection of the brain, but also blindness, communicating to all of these other structures. So these are kind of our no-fly zones. Glabella, I don't like, there are injectors who do inject frontalis. I am not a giant fan of that area. So what are our alternatives if we're not going to use dermal filler here? There are lots of different things we can do. I mean, the gold standard for our frontalis is going to be neuromodulator primarily. We can also use PDO threads. I have a couple of test cases that we're just meshing the frontalis, and we're seeing really good results with that. So we do have options that do not include dermal filler. In the nose, I have injected noses when I worked in plastic surgery, but we have the ability to take that person to the OR should something go sideways. So I stay completely clear of the nose as an independent aesthetics provider because I don't have an OR right next door that I could take someone to. So if someone needs something done with their nose, I'm probably going to send them to a plastic surgeon for rhinoplasty or even a liquid rhino because I want it to be done in a situation that's safe for the client. Temples is another area that we tend to focus on with our dermal filler. There's a couple of techniques we can use. I think the safest thing you can do is using a cannula here. You can also, there's some PDO thread information that twist threads can volumize that area. I think you'd have to put a lot of threads in there and you'd have to go several rounds to get an adequate fill, but that certainly is an option. But using cannulas really can be helpful in mitigating some of these problems. And it's recommended that 25 is the smallest gauge because that's least likely to perforate an artery. Moving to We always want to be mindful when we're working in the tear trough area. Not only do we have this infraorbital foramen with the infraorbital artery coming out, but we have this potential to get into this angular artery if we're not minding our P's and Q's here. So that's something to be mindful of. The other thing we need to be aware of, which is a little bit outside the scope, is the lymphatic system of the under eye. And there's a lot of research now that some of these chronic malar edema issues have to do with plugging of the lymphatics. So really choose your filler clients with care. It is actually recommended, at least for starters, staying under this retaining ligament. So you're technically not in the tear trough at all, but that can be a much safer alternative there. Now, when the midface, when we teach midface and basic, we teach you guys the bolus technique, supraosteal or periosteal boluses, where we're putting a small amount of product right on the bone. And as you can see, if I were injecting Saskia's midface, this is an area that's really probably one of the safest areas of the face. Here's the great news. Most people should have their midface addressed first. So this gives us an option in a very safe area so that we don't need a lot of filler oftentimes in our tear troughs and LFs and even in the marionettes, because by revolumizing that midface, we see improvement in all of those other areas. So we almost don't even need an alternative here because it is such a safe area. This is also an area that can be, cannula can be used, which is my preferred method for treating midface, but there's absolutely nothing wrong with using a sharp needle here. Nasolabial folds. When I got into the aesthetics industry, we filled nasolabial folds. That was the thing. Everybody came in, and then we started seeing people on television and kind of making fun of, oh my God, look how overdone they are, because this kind of over volumization of the nasolabial fold kind of gives you that kind of apish look. So this is an area I very rarely fill just the NLF. In some cases I will, but there are alternatives we can use here. We can use PDO threads for mild sunken NLFs. We can use more superficial fillers here. The main thing to remember is this artery is coursing all up through here, so we have to be mindful that it's there. This is an area of the face, if you're using a sharp needle, you definitely want to aspirate with every pass, only injecting retrograde. We don't want to be pressing product potentially into a vessel and then threading it all the way up there. So, and then you can also use that supraperiosteal bolus technique coming right into the piriform space and laying a small bolus right on the bone. And I'm going to go through kind of some just general pearls at the very end. But those are some options that we can use in that area. Vessel I totally forgot to bring up here is we have the inferior branch and the superior branch of our labial artery. And in most people, it lies a lot like this. It comes right along the mental crease. However, in my research, there's a fairly large subset of people that this labial artery lies right in the vermilion border. I was like, oh my goodness. So again, in our lip area, and from these, there's little communicating arteries that feed the lips. And most of us have a really nice collateral circulation in that perioral area. So if you were to occlude in one space, you would have collateral circulation. But if the person has trauma or congenital abnormalities, we can't rely completely on that. So when we're in that vermilion border, again, aspiration is key. Potentially even using a cannula there could increase your degree of safety. Another option, which is one of my personal favorites, are PDO threads. I use a lot of twisting threads in the vermilion area. I think it gives a very nice support, and it's a very low risk procedure. So that can be a really beautiful area. Now, when we start thinking about jawline, we have to be aware of this artery coming up here. We also have a mental foramen that has a little bit of a vessel coming up here, the mental artery. And I can't remember what class I was in, but one of the doctors says, just remember, arteries follow valleys. Well, that's very inconvenient for us because we're trying to poof up the valleys. So we just want to be really cautious in this area. I typically will use a cannula in the jawline area. You can use a sharp needle for the angle of the jaw for sure. You can make entry points at the midline and inject this direction. Typically, I will make mine in anterior to this foramen, and then I'll fill this direction, and then I slide past that artery to fill this direction. But there's several different options. The other thing that can be really helpful for jawline are PDO threads again. We can use those in the prejowl sulcus and in the little, as our friend Wendy J talks about, the martini glass, creating that angle of the jaw. And using those twisted threads there can actually create collagen stimulation and mitigate the risk. And those of you who know me and my practice, the introduction of PDO threads was a game changer for me with dermal filler. And my dermal filler needs and uses have changed with the PDO threads, but that's a whole nother class. So I hope that that's a really nice kind of wrap up. Now, we were looking at photographs and talking about signs and symptoms. And I think as injectors, the most important thing is knowing your anatomy, knowing that these vessels are here, knowing that they're lying in wait for you. So knowing your anatomy, knowing when you're in an area that can be more risky is super important. And like I said, when you add up the percentages of glabella, frontalis, and nose, that's almost 75% of the cases of blindness come from those three areas. So for me, I got into aesthetics because I was tired of worrying and staying awake at night about the sickness of my patients and did I mess up? Did I do something wrong? I don't need to lay awake at night worrying about somebody having a vascular compromise. So how do we know? How do we know the difference between a bruise, for example, and a reticular appearance? If you just look at a photograph, and we saw some on Instagram fairly recently of bruise versus vascular event, pictures don't tell you the story, right? We're very committed that injections should be performed by licensed medical professionals. If I look at my hairdresser, for example, and say, can you tell me the signs and symptoms of ischemic changes in the skin? She would probably look at me with a glazed look on her face, just as if she were to ask me how to color my own hair. I have no idea. It's not my area of expertise. So non-licensed, non-medical people do not need dermal filler in their hands. It is dangerous. It is terrifying. They have no idea the anatomy, and they don't know what to do should something go wrong, okay? So the main thing, first, know your anatomy. Second, know your signs and symptoms. Now, we've all had a client in our chair, especially like when I'm in the chair, ow, 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 that hurts, that hurts, that hurts. This is pain disproportionate to the procedures that you're performing. So if you see this change in color and have pain, especially pain perhaps away from the site, that might be a referred nerve pain, this is a big red flag. If we see blanching, this is a big red flag. This means that the skin has been compromised, the blood supply has been compromised. We also might see pupillary changes or changes in extraocular movements. So for example, I might have a bit of a disconjugate gaze. One of the case studies that you can read about online talks about the patient had immediate blanching in the frontalis, and this was a glabellar injection, and then the eye tracked off. and within 24 hours, the eye was completely glazed over and the patient was blind. So we really, when that patient says this really hurts, we need to not poo-poo that. We need to be on top of giving them a break and let's see what happens, and really watching that skin, watching the tissue, looking for those ischemic changes. Now, should this occur, what in the world do we do? Well, my first thing would be change my diaper. And then we really need to spring into action because we have 60 to 90 minutes to restore vision. Now, there are some people who advocate retrobulbar administration of Hylenex or hyaluronidase. Personally, even with a 25 gauge cannula, I don't know that I'm super comfortable trying to get underneath her orbit. Several of the articles that I read actually discourage that by non-ocular specialists. So, but you can infiltrate all around the eye with hyaluronidase. And the reason for that is because we've seen demonstrated that it permeates the vessel wall. So if we surround the area with up to 1,500 milligrams of Hylenex, we can potentially, and this is just to get us to the hospital, because your next order of business is getting this person, if they are experiencing visual changes, to a hospital that has an ocular specialist. For us, that would probably be a level 1 trauma center. It would probably be OHSU or Emmanuel. And me and my client are going to go there, and probably via ambulance. So this is a true emergency. I hope to heaven it never, that I don't ever have to do this, but I need to know what to do should this occur. And so do you. If you're injecting these products, and you've heard me say Hylenex, hyaluronidase, the first thing you need, this is the antidote. This is an enzyme that breaks down hyaluronic acid fillers. So this, if you were injecting filler without this in your presence, you are setting yourself up for a disaster. This is the most important thing you can have in your toolbox. Aspirin has been shown, and think about cardiac reperfusion. This is exactly, we're reperfusing ischemic tissue. So aspirin decreases that platelet aggregation and can potentially thin the blood so that it can circulate through the collateral circulation and potentially break down something that might be in a vessel. So we want that. Nitropaste it's kind of out there. We do keep it in the office. I would use it if in the appropriate situation. But one thing you need to be mindful of is that nitro does drop a blood pressure. And I don't know about any of you who worked in the ER or critical care and would put that inch of nitro paste on, and the next thing you know, the person's blood pressure bottoms out. So if you are using nitro paste, you want to use a very small amount contained to the area of ischemia, and you really want to be able to manage their vital signs. You need a blood pressure cuff. You probably, it wouldn't even hurt to have IV fluids on hand should something, should you need to deal with a hypotensive patient. I think, let's see. Oh, some other things that I came across in the research are a massage of the globe. So close your eyes, Sauce. So it actually advocates, it's almost like eyeball CPR, and you can dislodge the clot by pressing down on the globe for 5 to 15 seconds and releasing, and you want to continue that cycle for about 5 minutes. And what that does is it changes the pressure in the eye. There's also timolol eye drops can be used to decrease intraocular pressure, and all of those things are kind of like, I equate them to back in the day when we gave mannitol for head injuries, creating space for collateral circulation to occur. So those are kind of the options. Again, dermal filler, let's talk. I kind of glazed over that. Options, if you did feel compelled to use a dermal filler in the frontalis or glabellar region, you want a very low G prime that can be injected into the dermis. You do not want to be down where those big vessels live. And there are clients who will ask me to use dermal filler in their glabella. Well, number one, if I were to just throw caution to the wind and do it, even though I know it's dangerous, as long as there's still movement in that glabella, the filler is going to be dispersed by the movement. So you still need to use a neuromodulator. And the lion's share of people will get rid of those big 11s if they stay on track with their neuromodulators. For my negotiation with people is, give me 1 year of every 4 months treatment, and then if we haven't arrested those lines, then we'll consider other measures. But I really want to give that neuromodulator a chance. Again, glabella options could be staying on your neuromodulator. We can also use PDO threads in this area. And I can't remember if I talked about that, so I wanted to go back to it. So I think we've covered most of the anatomy that I wanted to. Again, remembering that this cavernous sinus is the venous version. It's kind of the venous version of the circle of Willis when I looked it up. And that is what Dr. Pimple Popper, Dr. Oz, my grandmother, all called the triangle of death. And the theory is that because these vessels anastomose behind the scenes and they're all kind of interconnected, that when we're in these areas, which would be from here to the corner of the mouth, a little triangle, I'm only going to draw the triangle on one side, that we have increased risk of infection, but we also have that increased risk of infection is because of the communication of vessels. And because of that communication of vessels, this becomes a very significant zone for us with dermal filler, not because of the potential of infection, but the potential that something that I inject here could wind up in the central retinal artery, which is exactly where I don't want it, or into that cavernous sinus, creating a thrombosis, or which can lead to cerebral infarction. So there's really some fairly serious things that can happen if you, A, don't know your anatomy, B, don't have the tools that you need should something go wrong. So hopefully you will add all of those things to your toolbox if you don't have them there already.
Okay, let me switch out for just a second because I just want to.
I know Wendy has a few things to say.
Okay.
Let me get in. We'll trade.
So when we are talking about the dermal filler danger zone, like Kathy just said, that deadly triangle. So it's here going down all the way here, actually including the lips.
Are we corner of the mouth?
Are we going to stop injecting lips? No, absolutely not. So let's say my patient comes in and they've got these strong glabella lines and they say, oh, I've seen people put Juvederm in there or whatever robust filler that I know is going to create problems, and I'm a safe injector. My options to my patient at that point are some finely whipped filler in there, maybe injected very superficially. Option 2 are my twist PDO threads that are super easy and very safe. So I'm not going to occlude vessels by doing either of those things. I'm not going to create edema that's going to occlude vessels by doing either of those treatments. Super safe, right? Moving on, somebody wants me to inject their nose. The first thing I'm going to say is absolutely not. And then I'm going to explain to them why I will not do this. Our position statement as at Pacific Northwest Aesthetic Academy is that you don't ever inject this area, regardless if you're using a cannula, you're shoving PDO threads up there. We just advise not doing it. Send your patient to plastic surgeon. If they want a definitive treatment, that's what's going to be their best option. Moving down from there, in the tear trough, how do I become the safest possible injector? I'm going to use a cannula. I'm going to know my anatomy. I'm going to use those techniques that I know are much safer than grabbing a needle and just going for it. So cannula in the tear trough, knowing your anatomy and getting very good education on how to do that, the techniques of how to inject the tear trough area. Moving from there, our nasolabial folds. We've rethought this now, and we will be revising our curriculum to reflect that, because what we thought was a pretty safe area is actually not. It is one of the most common areas to have a dermal filler vascular occlusion episode. So using a cannula in this area, thinking about cheeks first. When we lift the cheeks, this is a very safe zone. When we lift the cheeks, look what happens to the nasolabial fold. So always, when you have a patient come in who says, I want my nasolabial folds filled, they usually don't say that, right? They say these deep creases or whatever, you're going to think about what can you use to lift that area. So I can use my filler, and I can do periosteal boluses, which are very safe. I can use PDO threads. Start here, they go and they target that fold and they pull back like this. So those are the two very safe things that I can do in that area. Again, we would start our threads here, put them down this way, and pull that back. So rather than flattening out that nasolabial fold or by sticking some dermal filler in there with a needle, which can be dangerous, I'm going to consider the other options. My last choice is going to be use a cannula. So I would insert my cannula here and come up here and and lay down some dermal filler that way. Or if it's a more superficial line, then I can again use my PDO thread and do a curly Q of PDO thread right in there. Moving on to the lips, which we know, we are not going to stop injecting lips. How do you become the safest possible injector in this area? You follow the simple techniques that you learned back in basic training. You're going to insert your needle, you're going to aspirate, you're going to watch for the signs and symptoms of dermal occlusion, because that can happen in the lip area. You're going to know your anatomy. You're going to have your medication ready on standby in case something should occur. And you can also consider using a cannula in this area. There's a lot of people who use cannulas in the lips and they look fabulous. It is a very safe technique. When you're using cannulas, make sure that you're using a cannula that is a wider gauge cannula. So a 27 gauge and a 30 gauge cannula can be pretty sharp. So remember that the smaller gauge cannula you use kind of equates to the vessel lumen, which are typically around 27 gauge. So if I've got a 30 gauge cannula, I can perforate some vessels. I can actually cannulate some vessels with that cannula. So the takeaway from all of this is use the safest possible technique and use your adjunct devices to help you remain as safe as possible.
On those adjunct devices, again, we talked about cannula size, 25 and up being the recommended. There's also some vein fighters that you can use. There are different ones on the market. I have not personally used them, but I think if it would make you feel more comfortable in your practice, the problem I see with those is that I can't necessarily identify what's what, but at least I can see the big juicy vessels and stay away from them. So that can be something that can be employed. And that was weird. So yeah, you can use those sorts of things. You can use threads. Use your neuromodulators. Learn those off-label areas for the downturned corners of the mouth. We know that neuromodulators are incredibly safe and that the complications from them are incredibly rare and really have no long-lasting sequelae. We might create an asymmetry or something like that, but they don't tend to have long-term problematic things. So, I mean, I'm a big fan of neuromodulators as well. And other areas, again, we talked about the PDO threads. Another nice place for a curly Q, like I mentioned, is right here in the prejowl sulcus at the angle of the jaw to create that volume there. And I think that's the only other places I can think of that I might use PDO threads. Just thinking about, and I think the thing to be mindful of is there's not one thing. There's no silver bullet that's going to save your bacon and make you the safest injector you can be. It's knowing all these things and using all of these tools. So am I going to say a person who uses a cannula can never have problems? Absolutely not. Am I going to say a person who always aspirates can never have problems? Absolutely not. These are all tools that help us be safer, but we can potentially still have problems. I know my anatomy. I use cannulas. I use alternatives. But in the back of my mind, every time I poke someone in the face with dermal filler, I am aware that something could go wrong. And I have to be mindful of that. And I, have to be prepared for it.
Can you talk about the anatomy some more and the other tools that we use for that?
not sure what you're asking me about.
The textbook that we
Oh,
have
yeah,
that
yeah.
we really recommend.
Yes, this textbook we absolutely love, facial volumization, an anatomic approach, and there's some fabulous anatomy in here. And with this book, when you purchase the book, and it is available on Amazon and I'm sure several other places, but there are several videos as well that are included, injection techniques. Some of them are different than what I would do, but very interesting. And I think we always have to be on that quest for knowledge and be open to different techniques, because this is probably the fastest growing industry I have ever in my life been involved in. My gosh, I took my first ACLS class in 1985, and there weren't a lot of changes, bicarbs in, bicarbs out, every now and then a new med, but this has evolved so much in the last 8 years I've been involved in the aesthetics industry. It's utterly fascinating. So we have to be open. We can't just say, well, this is the way I've always done it. We have to always be open to learning new tricks and new techniques.
The other things about knowing your anatomy, take a cadaver lab. If you haven't yet experienced seeing somebody's face filleted open while somebody's doing a live injection right next to them, that is a huge tool to being able to visualize those areas so much better. And I finally went to my first cadaver lab when we were at the Scale conference in Nashville last summer. And, you know, I'd been wanting to go for a while, and I was like, oh, I knew it was going to be helpful. I had no idea how helpful it was. So now when I'm injecting my dermal filler, I'm actually visualizing what's happening under my patient's skin. And it really hits home. Knowing your anatomy is so key when you're poking needles into people's faces. So we have some conferences that we really recommend highly, and they also have cadaver labs either as a pre-conference breakout or during the conference. And the first one that is coming up the soonest is the LAMCA, and it's the Los Angeles Multi-Clinical Specialty Aesthetic something. But if you look for LAMCA, and it's in Los Angeles, it's March 26th through the 29th. Really good opportunity to see some amazing speakers, very content-rich course, which you know we always recommend. And there is a cadaver lab. The next one would be the Scale conference, which is always in Nashville, Tennessee. And they just moved the date of this one. It is in July. It's 22nd through the 25th. That one is incredible. It's got several tracks for estheticians, dermatologists, doctors, nurses, aesthetic injectors. It's really a super educational, content-rich conference. And then finally, the one that we just returned from is the iSpan conference. It's in the International Society of Plastic, Surgical, and Aesthetic Nurses. And if you're not a member of that organization, get online and join today. It has some amazing references, tools that you can use to help become a safer injector and just a better practitioner. So in 2020, that conference will be in San Mateo, California, and that's October 15th through the 18th. And the author of the facial volumization book is Dr. Chris Surratt. If you don't follow him already on Instagram, follow him. I saw him speak at iSpan, and he is the most knowledgeable person when it comes to anatomy and safe injections that I've ever heard speak, and just very engaging. So I encourage you to watch Dr. Surratt, and if you have the chance, take a training from him. I understand that his trainings are booked out through fall of 2020, so he's really that popular.
Also, Dr. Lamb is co-author, and I've actually seen him speak at iSpan a couple of years prior. I will say, just to kind of ring into that iSpan, or excuse me, not iSpan, but Scale Cadaver Lab, that was done differently than I've ever seen before. I've been to, I think that was my third cadaver lab, but this is the only one of where I've ever seen them do a split screen of the cadaver and a live injection. And they demonstrated the injection in the cadaver and then on the model as well. So it was a really interesting way to kind of see that content presented.
Where most of the cadaver labs are just cadaver, and they're just showing you the face, and they're not comparing it to the injection. Is that how it typically runs?
Yes. Now I have seen them inject like colored dye, but just in the cadaver, just showing you kind of these anastomoses and the vessels and whatnot. But that was the first time I'd ever seen them do a live demo and
Side by
cadavers
side.
side by side. And I felt that was incredibly, it was just a different way of presenting the material, which I thought was really powerful.
Yeah, and the other thing that everybody in attendance noted was that the doctors who were doing the injections on stage were not aspirating. And of course, somebody said, you know, doctor, how come you're not aspirating? And which is our reply always too, is that it doesn't mean you're 100% safe. I mean, this person is a plastic surgeon. He sees the inside of faces all the time. So his comfort level is different than ours. And with 100% certainty, probably he knows that he's not in a vessel. I don't have that kind of comfort. I'm going to aspirate every time. It's not always, you still can be in a vessel and not get any blood back, because we know we're using a 27 gauge needle and we've got at least 1 ml of an HA gel. So sometimes there might not be enough venous or arterial pressure to push back into the syringe. So just remember that we want you to aspirate. That's a safer way to administer your dermal filler, but it's not 100% certain that you're not in vessel.
And I mean, aspiration is a technique I've had to learn. When I was trained in injectables, I wasn't even told that vascular events were even a potential problem. I probably would have quit immediately had I known before I ever started. Fortunately, I did not. But sorry. So, but I've had to learn to aspirate. And I kind of equate it when back in the 80s when I was a nurse and we started wearing gloves, several of my colleagues would chop the fingers off their gloves to start an IV, which pretty much defeats the purpose of using that protective device. So it's a technique you need to learn. I'm getting better at it. I've been called out by a few students myself because aspiration was not part of that muscle memory for me. But the more I prepare and the more that I learn, the more that I know. I want every tool that I have to make me the safest, most effective injector that I can be. And I think obviously we got into healthcare because we want to care for people and we never want to cause harm. So I think we've covered most of our material. Wendy, do you want to open up for questions at this point?
Yeah, if you all have any questions or if you want to see any of the areas of the face that we're talking about, I just typed in the name of Dr. Surratt, and I will also put in the name of the textbook that we recommend. And you all should have my email. You will get a eval on this webinar, and I will send this information that we've covered on the references to you in an email. So just opening it up for questions. If anybody has any questions, we'd love to hear it, and any input, because we're always learning too. And so we totally welcome anything that you all have heard elsewhere, or any tricks and tips, any pearls that you have that can lead us all to being much safer injectors. Do you have anything you can say about STS use?
Sodium thiosulfate. Yes, good question. So, and that kind of brings me back around to hyaluronic acid fillers. Obviously are very safe because we can dissolve them instantly. Sodium thiosulfate can be used to break down calcium hydroxyapatite. Brand name in the US is Radiesse. I think Radiesse has gotten a little bit of a bad rap as being unsafe because you can't dissolve it. I use a lot of it in my practice. I don't think as a brand new injector, it's wise to use something that you can't get rid of. You need to be really confident in your skills and placement. But what sodium thiosulfate is shown to do is begin to break down the calcium hydroxyapatite. It is not instantaneous. That process begins in about 24 hours when you start to see that breakdown. So if you have a vascular event with your calcium hydroxyapatite, you're going to follow the same protocol. Personally, I'm still going to use my Hylenex or my hyaluronidase because, again, that concept of creating more space for the peripheral circulation around the area can be helpful. Is it going to break down the product? No. But the primary target for the the sodium thiosulfate is more for an aesthetic, an undesired aesthetic result. For example, I actually saw someone who had mid-face done and inadvertently got calcium hydroxyapatite in the tear trough. It took about a year for that to go away. And at that point, we had no recourse. So that would be a really great time to use your sodium thiosulfate to begin to break that down quicker. If I had a vascular event, I would absolutely use that in conjunction with the hyaluronic acid, because I want to do anything I can to increase that blood flow.
Kimberly would like to know if we offer internships.
We do. What we typically will do is set you up as like job shadows so that you can be with Wendy or I, or we also periodically will do filler refreshers, and we will book patients for you, and we will allow you to treat them under our supervision. So we do that. We're actually looking at, I mean, it's kind of been on an as needed basis, but I actually would like to add a filler refresher like once a quarter, just routinely to our calendar. So if that's something that you all think would be of benefit or you'd be interested in, please let us know, because we are here to meet your needs for that.
Absolutely. And just on the kind of being scared of the things that we do, you just have to remember that, you know, you just have to be mindful. And the injectors that are most mindful of the problems that can occur are the safest injectors. So when we're teaching basic injectable course dermal filler day to healthcare providers who've never done these before, they're like deer in the headlights. They're scared. But really it comes back to being using the safest possible technique. So you're going to know your anatomy, you're going to insert your needle, and you're going to inject in a retrograde fashion, you're going to aspirate, you're going to do all those things you know already to be safe. So, and you're going to be ready. We had a student, a former student, a graduate, who didn't take our class too long ago, and she had a dermal occlusion episode that happened in the lips. And she saw it immediately, and she treated it immediately, and the patient is healing fine with no sequelae at all. So it's scary, but just make sure you have that arsenal ready to go. And I seemed like there was something else I wanted to add to that, but I don't remember. Any more questions? We'd be happy to talk. We also are very open to people dropping in to our office during our training weekends. So between 1 to 6 to just see what we do, check us out. We've got many courses that we offer, and I feel very strongly for letting people come and take a look and see our environment, and we hope it translates to your environment. Keeping things sterile, keeping the lighting good, all those things are very important to us. They definitely add to the safety factor. Another note that Kathy and I will be doing a YouTube video soon is about the do-it-yourself filler issues that we're having more recently, or maybe they're becoming more publicized, but it's those people who somehow get their filler online and are injecting their own faces. The other position statement that I wanted to make clear, and you will also hear it in our YouTube video, is that we feel very strongly, and it's our position at PNAA, that injectors should not inject their own faces with dermal filler. Doesn't seem like it should need an explanation, but you could just as easily inject your own face and inject right into a vessel. It's the unsafest thing that I've ever seen injectors do. And the only time I see it, of course, is when they post it on social media, and it makes me cringe. So our position is, do not inject your own face with dermal filler. And if you do, like, it is a really, really bad move to post it on Instagram.
This is why we have friends and colleagues, so that we can inject each other. We don't have to inject ourselves. And I really, the DIY filler is very interesting. In preparing for this, I just typed in DIY filler, and the first thing that pops up is Amazon.
Oh, goodness.
So just, again, I won't go into that, but you have no idea what you're getting. True product that is FDA approved has to come directly from the medical, from the company. And the only way for that to happen is that you have a licensed physician or someone with prescribing privileges and their DEA numbers, et cetera, et cetera. So anything you're ordering, you have no idea what it is. They may say it's X, Y, and Z. I've actually had a couple of clients who have come in with DIY filler issues, and sometimes you can break it down. Sometimes these things are contaminated with silicone and all kinds of horrible things. Who knows, caulking. They're just not products you want to put in yours or anyone else's face. And of course, when we're working, it looks easy. That's our job. We want it to look easy. We want our client to be confident in our ability. So when when I'm injecting Saskia's face, I don't want to be like, oh my God, I'm so scared. I want to appear confident. And it does make it look easy. And I'm sure if you put a YouTube video of me up doing procedures, someone might say, oh, this looks super easy. But they don't have that background knowledge. So that's, again, I could go on and on about that, and will very soon on the YouTube video. Any more questions?
Another thing that we want to emphasize too is that we are very committed to mentoring. So even if you're not able to come hang out with us, or you live far, far away, we are a phone call away. And we really want to stress that safety should be important in our entire community. And if we can help you become a safer injector, it's just leads to just helping the industry in general and increasing our patient safety. So please don't hesitate if you have any questions after this webinar. If you have any questions ongoing, you can text us, you can call us, you can email us. We are more than happy to assist in any way that we can, or also to guide you towards a plastic surgeon or somebody if the issue is needing something that's more in-depth than advice that we can share with you. But we are committed to mentoring all injectors so that our community is safer as a whole.
Well, thank you all for attending. It's our pleasure to share our information with you. I think this industry, there can be a little cutthroat, I'm not going to tell you my secrets because you'll steal my clients. There are plenty of clients for all of us. And I really think the most important thing we can do is support each other in our quest for knowledge and safety, and make our industry the respected subspecialty of medicine that it should be. And we do that by using great techniques, only working with licensed medical providers, and using products that we know are legitimate and real.
Thank you for joining, everybody. Have a great day, and we hope to see you soon. Follow us on Facebook and on Instagram and our YouTube channel.
Have a great day.